A healthy life means not merely physical health, but also mental of every individual. A healthy and productive population is the state's pride, and Tamil Nadu stands by its motto, health for all, by providing affordable, equitable and accessible healthcare services. In the evolution of medical education and healthcare, the Madras Medical College, the second oldest college in India, and the century-old Directorate of Public Health and Preventive Medicine, in operation since 1923, stand out as evidence to the state's rich legacy. Tamil Nadu boasts of a robust healthcare network spanning the entire state. Tamil Nadu is home to 36 medical colleges, the highest number in the country. Through provision of high-end equipment, leverages advanced medical technology to enhance healthcare delivery. Robotic surgery provides advanced healthcare solutions through precision and minimally invasive procedures. 28 cath labs across 20 institutions offer state-of-the-art treatment for heart-related conditions. 11 linear accelerators provide precise radiation treatment for cancer care. 9 brachytherapy units offer effective internal radiation therapy for advanced cancer treatment. The state is equipped with 15 cobalt therapy units, delivering affordable and effective radiotherapy services. 139 dialysis centers are equipped, providing comprehensive and accessible renal care for pregnant mothers and newborns. The Tamil Nadu government, through various impactful programs, ensures safe motherhood and 100% institutional deliveries. The state has commissioned state and district task forces to reduce maternal mortality rates and operationalized the War Room at the National Health Mission. The state-level Pick Me call center intensively tracks down high-risk mothers and intimates those deserving immediate care. The calls are closed through the Pick Me portal. Dr. Mutalakshmi Maternity Benefits Scheme provides financial and nutritional support to mothers at a value of 18,000 rupees, which includes 14,000 rupees in cash and 4,000 rupees in kind, given as a mother-baby care kit. The 129 Seemonk centers offer round-the-clock emergency care for mothers and newborns. Remarkably, 80% of government deliveries occur in these highly specialized centers and sets a benchmark for public health initiatives in India by achieving reduction in maternal mortality. Immunization campaigns are conducted with a special focus on reaching the underserved. The Makkalai Thedi Maruthuvam scheme is conceptualized in such a way that a vibrant field-level team provides home-based healthcare services to its beneficiaries. Comprehensive diagnostic tests offered free of cost to all patients across government facilities. A robust sample transportation network across the state ensures timely transfer to high-level laboratories. Equipped with high-end cutting-edge technology, provides advanced diagnostic services and disease surveillance systems. Geriatric healthcare is vital to ensure the well-being, dignity and quality of life of the elderly, while promoting active and healthy aging. National Centre of Aging, a premier institution of national importance, provides specialized geriatric and palliative care. Tamil Nadu's initiatives for tribal populations emphasize provision of access to inclusive, equitable and quality healthcare. Feeder ambulance services for remote tribal areas ensures connectivity and referral services. Tribal mobile medical units delivers essential medical care and screenings to underserved tribal areas. The government of Tamil Nadu introduced the Chief Minister Kalainar Insurance Scheme to economically underprivileged families. In 2018, it was integrated with the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana.
எனக்கு ஆல்கஹால் குடிப்பழக்கம் இருந்தது. லிவர் டேமேஜ் ஆயிடுச்சு, ரொம்ப இதாகிடுச்சு. ப்ரைவேட் ஹாஸ்பிட்டலில் 34 லட்ச ரூபா கேட்டாங்க. சிஎம் ஸ்கீம்லேருந்து 22 லட்ச ரூபா எங்களுக்கு சேங்ஷன் ஆச்சு. அந்த புல்ல அதில் தான் ட்ரீட்மெண்ட் பார்த்தது. இந்த கவர்மெண்ட்டுக்கு கண்டிப்பாக நான் நன்றி தெரிவித்து தான்.
Under the scheme, 86.5 lakh families in Tamil Nadu have been covered.
என் பேர் வந்து பாலு. 2021 கேன்சரால் பாதிக்கப்பட்டிருந்தேன். அடையார் கேன்சர் இன்ஸ்டியூட்டில் வந்து செம்சல் தெரப்பி எனக்கு பண்ணியிருக்காங்க. இப்போ முதலமைச்சர் காப்பீடு திட்டம் தான் எனக்கு இப்போ அந்த அதுலேருந்து அமௌண்ட் தான் எனக்கு வந்து இப்போ போயிட்டுருக்கு. எனக்கு வேறு எந்த ஒரு பைசாவோட நான் செலவு பண்ணதில்லை. எல்லாமே தமிழ்நாடு இன்சூரன்ஸ் காப்பீட்டில் தான் எனக்கு போயிட்டுருக்கு. எனக்கு
A dedicated corpus fund has been established to cover high-cost procedures, ensuring access to life-saving care in both government and private hospitals. Since its inception, the Tamil Nadu state government has made significant strides to reduce accidents and save lives, with the 108 ambulance service playing a vital role across all 38 districts with fully trained EMTs and pilots. A fleet of 1,353 ambulances provides pre-hospital care, which includes basic, advanced and neonatal life support units, besides the 41 first response bike ambulances. The statewide average response time is 13 minutes and 2 seconds. Innuir Kappum Nammai Kakkum 48 stands out for its inclusivity and life-saving care, offering up to 2 lakh rupees coverage within the first 48 hours of treatment for accident victims, not just for residents of Tamil Nadu, but for all, regardless of nationality, because every life matters. Tamil Nadu has a total of 723 approved hospitals under the scheme, with 250 government and 473 private hospitals, ensuring widespread access to quality medical care.
பைக்ல போயிட்டு இருக்கும்போது எனக்கு ஆக்சிடென்ட் ஆயிடுச்சு.
போன பிளட் போயிட்டே இருக்கு, தலையில அவ்வளோ ரத்தம் போயிட்டே இருக்குது, கண்ணெல்லாம் பஞ்சு அடைஞ்சு போச்சுப்பா. எங்களுக்கு அவ்வளோ வசதியே இல்லாம நாங்க திரும்பி அங்கே சேர்த்தோம். அந்த காப்பீட்டு திட்டம் இல்லைன்னா எங்களால் இன்னைக்கு என் பிள்ளை கிடையே கிடையாது.
இப்போ நான் உங்ககிட்ட இந்த மாதிரி பேசிட்டு இருக்கேன்னா அதுக்கு காரணமே NK48 ஸ்கீம் தான். மொத்த செலவுமே கவர்மெண்ட் தான் பார்த்துக்கிட்டாங்க. நாங்கள் ₹1 செலவு பண்ணல. நான் இன்னைக்கு நல்லா இருக்கேன் அப்படின்னா அதுக்கு முதலமைச்சர் காப்பீட்டு திட்டம் தான் காரணம். நான் மட்டும் இல்லாமல் என் ஃபேமிலியில் இருக்கவங்க எல்லாருமே ரொம்ப சந்தோஷப்படுறாங்க.
இன்னைக்கு என் பிள்ளை நல்லா இருக்கிறான்ப்பா. இன்னைக்கு
3,22,837 beneficiaries' lives have been saved without financial burden under the NK48 scheme, with a claim approval of 282.12 crore rupees. A strong healthcare system in Tamil Nadu, which is built on the precepts of equality and inclusivity with humane values, delivers equitable healthcare services for everyone in the state, regardless of social background. Tamil Nadu stands tall as an epitome for having achieved these milestones and credentials, as is evident in the joyful and content faces of its citizens, leading a healthy and dignified life.
Welcome back, ladies and gentlemen, and what a lovely note to start our final segment on. This is the National Workshop on Strengthening Public Health Infrastructure under PM ABHIM. Of course, day 2 so far has been exciting. I'm sure each of the field visits have been an important component of each of your understanding, and right now the stage is all yours as we welcome each of the teams to join us and share their key findings. Before we officially begin, if we may kindly request all the teams to present their presentations, to share their presentations to the sound console on the other side. We have one team that has already shared their presentation. If I may please request all of the other teams to do so at the earliest. We're now ready to hear from our teams, ladies and gentlemen, their key findings based on the field visits that they've had today. Before we hand the floor over to our first team today, if I may please request all the team members to pay close attention to the next couple of seconds, in fact, because this is a reminder on the time. Each of the teams will be given 7 minutes for their complete presentations. At the 5-minute mark, we have a short bell, which will be a gentle reminder for you on the time. At the 7-minute mark, we have a hard stop, so please do conclude your presentation by then. We have extremely exciting presentations coming your way, so in the interest of time, we do not have a Q&A session on stage. However, we have the rest of the evening to keep the conversation going. And on that note, ladies and gentlemen, we begin with Team 2. This is a team that has visited the Block Public Health Unit at Kelambakam and the District Integrated Public Health Laboratory at Government District Hospital, Tambaram. If I may please request from Team 2, Dr. Priyanka Shukla, Mission Director, Chhattisgarh, Dr. Amit Yadav, Mission Director, Rajasthan, and Dr. Vikasendu Agarwal, State Surveillance Officer, Uttar Pradesh, to join us on stage and share their findings. As each of the teams make their presentations, if I may please request all members of the audience be seated and direct their attention to the stage.
Very good afternoon to all of you. So our team has visited one block public health unit, one integrated public health laboratory, and then we have prepared our presentation based on the field visit. So next, please. Next. Okay. So these were our team members. Our team was led by Shri Partharthi Sen Sharma, who is Principal Secretary, Medical Health and Medical Education for Uttar Pradesh. Where should I point it? No, I'm okay. And these are other team members. We have visited two facilities. First was Kelambakam PHC, which had a block public health unit, and the second was Tambaram District Headquarter Hospital, which had a district public health laboratory. So the Kelambakam PHC, it was an impressive setup, and the block public health facility was as per the textbook as Government of India has issued the guidelines. It was absolutely at par with the guidelines. It is a newly built building, and it has been developed under 15th Finance Commission. Then HR, all the recommended HR was available there. In fact, they have deployed the surveillance, they have designated a surveillance medical officer from the regular cadre of the state. One position though was vacant, which was public health expert. And they also had the support from two IELS transporters, which were transporting samples from the field to this block public health laboratory. The laboratory has a provision for 97 tests, and 35 of these are in-house, while 62 tests were being done in hubs. Laboratory services are available on a daily basis, and the average footfall is 40 to 50 persons per day. That translates to roughly 200 to 250 samples per day. And they are undertaking surveillance for malaria, dengue, scrub, and leptospirosis on a regular basis. So they have a very well-developed HMIS and LIMS, and there is a mechanism of IELS, which is working pretty well. And there is a seamless data integration between HMIS, LIMS, and IELS. But the linkage with IHIP is missing as of now, and it is desirable because it takes duplication of efforts to enter data on IHIP again. Then equipment, they basically had a microscope, semi-auto analyzer, and cell counter. Then innovation is that vector surveillance is also integrated at BPHU level. They are collecting samples, mosquito samples from high-risk areas, and then breeding these mosquitoes, hatching these mosquitoes, breeding them, and then doing the molecular testing for finding out the pathogen DNA in these samples. So one suggestion is that it should be, the state should try to integrate it with the IHIP so that duplication of efforts can be avoided. Then the district headquarters.
For the district IPHLs, we visited the Tambaram district headquarters hospital. And the health infrastructure, that hospital is built recently from the NHM funds, 110 CR crores. And it was built up after removing the earlier hospitals. There is a sufficient availability of HR infrastructure since it's a new building, so it is very good. Regarding the service delivery, number of tests for the microbiology are 28, biochemistry 38, pathology 41, total 107 tests are available. For the BPHU test of hub and spoke, they are coming at this lab. Next. For the data recording and reporting, same HMIS, LIMS, IELS is used. In every lab, there is the first sample collection points where they do the entries of the samples by the barcode readings. And then for the IHIP, integration is pending. Equipments, microscopes, semi-auto analyzers, fully automated clinical chemistry, hormones, electrolyte analyzers, cell counters, centrifuge ELISA, all tests of the cytology-related microbiology and biochemistry, all test machines are available there. For the lab reagents, they have the rate contracts through TNMSC. The challenges and gaps, one is the integration with the IHIP. Innovation is that because of the in-house tech facility, turnaround has been reduced, tag period reduced to 5 hours from the earlier 24 hours. And the color coding of the samples has been done for the faster learning. And there is a different procedure for the emergency cases so that priority-based reporting can be given. Every 3 hourly test reports are coming from the hospitals and they are put for the testings. Suggestions, interfacing of lab equipment with LIMS. Certain machines are integrated with the LIMS portal. For certain, they are in process.
Now, the takeaways from the field visit. As we have already discussed before, BBHO and IHL have been established and they have been made operational as per the national guidelines using 15 finance and ABHIM funds effectively. Human resources have been trained well, and the best thing about the human resources was that they have a great sense of ownership, which is generally missing in a lot of institutes. Successful in-house development and deployment of IELS, as we have mentioned before also, was very motivating for all of us, including effective and innovative sample transport mechanism, which ensures that samples are collected right from the homes of the patients. Innovative approach to NCD screening and sample collection has ensured that the burden on primary and secondary care has been reduced quite a lot. So this is something that we could see for ourselves that speaks volumes about the success of this model. We could see that the supply chain management is very well structured and it is very well functional also. And we could see that the proper utilization of primary health care mechanism has also resulted in reduced caseload. Vakkalai Tedi Maruthuvam, I hope I am pronouncing it correctly, is a good home-based healthcare delivery model. The best thing that we saw for ourselves was this integrated essential laboratory services where, patient just has to order the test and the samples are collected, and through IELS, the sample transport is monitored. The order is processed, and while sample gets examined at the DIPHL, the results and reports are uploaded through LIMS and results are interpreted at that particular facility where the sample was taken, which is a beautiful model to ensure accessible quality healthcare services.
So if we talk about challenges overall, then continuation of committed grants is one big challenge. And we need human resources. We are developing a lot of physical infrastructure, but human resources are also required to make this infrastructure functional. So sustained support is required there. Then the assets that are being developed right now, they will need maintenance later on. So there should be some provision for maintenance as well. And then secondary care has to be redeveloped because most of our district level hospitals have been converted to medical colleges. So there should be some thought on that also. Then expectations, we expect continuation of committed grants. This is very much required. Then sustained support for human resources. Then there is one very key observation that many states are developing their own portals, their own innovations in digital area. So the systems, the portals or digital interfaces that Government of India is developing should be developed in such a way that they have easy API linkages. The API documents are easy to consume. We are facing some problems in this regard in UP, like IHIP, we have been trying to consume, but then this has to be taken care of. Then there should be quick rollout of HMIS and LMIS. Then sustainable models for radiology, like teleradiology, should also be given some thought, and support for construction of new secondary care facilities. So that's all from my side. Thank you.
Thank you very much, Team 2. With that, ladies and gentlemen, if I may please request Team 4 and Team 5 to share their presentation at the console to have the maximum amount of time utilized. Of course, we are on stage witnessing the key findings and observations from each of our teams. Through the course of the first half of today, we had 5 teams visiting various parts of the city, from the outskirts to right in the heart of the city. Be sure that you have had your own individual findings that you're probably putting into a presentation right now. But in the interest of time, if I may kindly request all the teams to share their presentations to the sound console right there, and we will have it up on screen. Along with that, just a gentle reminder to all the teams in terms of time. May we please request all of your findings to be shared within 5 to 7 minutes at the latest. This will ensure that we stick to not only the timelines for this part, but also the rest of the evening. Ladies and gentlemen, we're here at Day 2, National Workshop on Strengthening Public Health Infrastructure under PM ABHIM. In fact, we saw Team 2 share not just their findings, but also a way forward in terms of PM ABHIM 2, a little bit of a teaser that was already discussed on stage yesterday, and today we're, I think, live witnessing how those very capacities can be built, those very gaps can be bridged, and that was, in fact, what Team 2 had presented. We're looking forward to presentations from Team 4 and Team 5 to be shared at the sound console shortly. Team 4 had a very interesting journey that they took to locations that they visited, and while we wait for their findings, if I may please request all teams to make sure that you are at full strength before the team members or the presenters join us on stage as well. We're going to wait a couple of minutes as we wait for the next couple of teams to join us at the sound console and share their presentations. Ladies and gentlemen, if we may kindly request all our team members to join us at the sound console and share their presentations. We're waiting for Team 4 and Team 5 to share their PPTs there. Once that is done, each of the teams will have a limited time of 7 minutes. If we may kindly request all teams to stick to their time. Ladies and gentlemen, it is now time for us to step into the next part of our presentation, where Team 5 will be joining us on stage to showcase their findings from their visit to the Biosafety Level 3 Laboratory, ICMR NIRT, here in Chennai. If I may please request our presenters to join us on stage. We have a clicker that is shared on the podium. Please do feel free to use that. We have Dr. Govindrajaji, Mission Director, NHM Pondicherry, who is going to be guiding the presentation forward. Over to you, sir. Good afternoon.
Respected Madam and my dear friends, on behalf of Team 5, I'm standing in front of you. Today morning, we visited a NIRT, National Institute of Research in Tuberculosis, which is an ICMR institute functioning at Chennai. Really, we had very good time in that research institute. This ICMR institute is an age-old one. It has conducted a lot of research activities in the field of TB. Now it has started the research activities in virology department also, and it is helping all national programs whenever some epidemics are happening. So it's playing a crucial role in doing that gene sequencing and identifying the disease pattern, epidemiology. So it has extended its field of study in various aspects, not only pertaining to TB research. So there we found that health infrastructure area is around 5,000 square feet. Actually, it is located in two places. One is having 1,000 square feet, another one place is 4,000 square feet. Human resources, more than 600 employees across the NIRT, but we visited the BSL-3 lab alone. In BSL-3, there are 3 scientists and 40 lab technicians, 12 NTEP staffs are working. And TB testing and research is the main component in that BSL-3 lab. Clinical trials and vaccine trials, a lot of things were carried out in that NIRT. More than 35 clinical trials were done. And main thing is home versus sanatorium study, which was done by NIRT, is a very big breakthrough in the management of TB treatment. And those days, earlier days, we used to admit all TB patients in the sanatoria. Then the drugs started to come one by one. After that, whether the admission is required, because we all know that admitting the patients for years together, what all the socio-economical effects it's having. So this NIRT did the home versus sanatoria type of treatment. After the drugs, when we started to use the drugs first, whether this admission for years together in the sanatorium is required. Then they found out that what is more required is regular intake of TB drugs, not the admission. Because we used to admit the patients for good air and free from physical, mental strain. We used to say a lot of reasons for that. But those things are not required. The important thing is regular intake of anti-TB drugs. That is the very big breakthrough. After that only all the sanatoriums were almost closed and renamed as either medical colleges or chest hospitals throughout the world. It's a very big breakthrough research, home versus sanatoria. And the sample transport system, they are using hub and spoke model. And a lot of samples are coming to NIRT through various field health institutions. Next. And of course, it's an ICMR project institute. It's giving its own fund. Apart from that, they are getting the fund from PM ABHIM also for their infrastructure development. And with that PM ABHIM fund, they are doing a lot of activities like a multi-center hub and spoke project and One Health zoonotic viral surveillance at Tiruvallur districts and research platforms. And Madurai, they are doing research throughout the Tamil Nadu, taking the limited populations. Advanced International TB Diagnostic Workshop is planned during the December of this year. Next. Conversion between NCD and TB project is going on well through that Makkali Thedi Marthuvam program. So they have formed a team which is going regularly to the field and doing that field visit. They are doing investigation not only for TB, they are doing NCD also, hypertension, diabetic screening, hypertension screening, and hemoglobin assessment, all these things. High-dose rifampicin regimen for TB treatment using gene expert and line probe assay for sensitive diagnosis. Training on good clinical practices and good laboratory practices. So being a national research institute, actually they are developing these good clinical practices and laboratory practices and giving it to all the other labs in our country, how we should keep the lab. Conducting research on innovation anti-TB regimen and developing strategies to identify and control TB in vulnerable population like prisoners and homeless. Actually, a lot of research studies are going on. pertaining to microbiology as well as pertaining to virology, pertaining to epidemiology also. Next. So these are the few instruments which we saw in that institute. BSL, Biosafety Level 3 facility, and midget culture with DST, and solid culture, all three type of cultures, and gene sequencing, which is accepted by WHO. But of course, Central TB Division is yet to accept and yet to escalate in our country. But WHO now is accepting gene sequencing as a very good test tool for diagnosis of TB. So this gene sequencing is utilized not only for the diagnosis of TB, it is useful for diagnosis of all other bacterial diseases as well as viral diseases also. So if we deploy this mission, it will be useful in future. This investment will be useful in future. When we are getting some viral epidemics also, that gene sequencing will be helpful to identify the virus pattern. And these are the air handling units for creation of negative pressure in the BSL-3 lab, and air handling units and the chilling units for BSL-3 lab. Next. And control panel which are fully computerized. Next. So this is a midget lab, midget 9, and solid culture lab. Next. So holistic approach in providing infrastructure support ranging from sub-center to district hospital is the expectation. And support for telemedicine hub and dedicated unit for HIMS. These are the 2.0, PM ABHIM 2.0 expectations. Infrastructure constructed under ERCP2, recurring budget to provide, to make them functional. It is an expectation from them through PM ABHIM 2.0. Incomplete 15th Finance Commission infrastructure component may be brought under PM ABHIM 2.0. This is their request. Support for upgradation of CSCs and subdivisional hospitals under next. This recurring support including maintenance should be continued to make constructed facilities functional, because we are constructing the buildings under PM ABHIM. To make it functional, some other manpower requirement, other things are there. So these are their expectations under PM 2.0. Funding linking of NHM and PM ABHIM, construction from PM ABHIM and optimization from NHM support, as I told you. So construction of building happening under PM ABHIM, but the optimization, they are expecting it under NHM support. More involvement of states in CS component, because under CS component, they feel the involvement of state is not up to the mark. Flexibility in costing and inter-component fund reallocation, investment in artificial intelligence and digital platform, budget allocation for lab equipment and critical care consumables. Next. Only the takeaway message: better coordination between assets created under center and state for disaster preparedness and Reliance Health System. Focus on surveillance by leveraging existing and new IT platform from grassroots to tertiary. Rational development of existing HR for optimization of facilities created under PM ABHIM. Partnership with the NDMC and the Similar Institute Bar Agency for modeling and predictive analysis by state. Thank you.
Thank you very much, Team 5. Ladies and gentlemen, a loud round of applause. Thank you very much. Of course, we know that sticking to the timeline will be a little difficult, but if we may please request all team members to bear that in mind as we move forward. Our next team on stage is Team 4. They had visited the State Public Health Laboratory at Thenampet, following which they also visited the 108 Emergency Management Center here in Chennai. If I may please invite Dr. Pinky Joel, Mission Director, NHM Uttar Pradesh, and Dr. Pradeep Khasnobis, DDG, DM Cell, Ministry of Family and Health Welfare, to join us on stage to take us through Team 4 and their findings. Welcome, sir. Welcome, ma'am. For all our presenters, we have a clicker that has been placed on the podium. If you would like a seamless presentation, please do go ahead and feel free to use it. Over to Team 4. May we please have the presentation on screen?
Good evening, all. We, Team 4. I'm presenting on behalf of Team 4. So, where's the presenter? So these are the members under the guidance of, where? Yeah. So our team comprised of these members, headed by Ma'am Gayatri Rathore, ACS Rajasthan. The facility we visited today was the State Public Health Laboratory State of Art Lab hai, and MMR is a maternal mortality room, war room for that. There is a portal called Pick Me under the TN Health System projects. Third unit which we visited was 108 TAEI Center, that is a Tamil Nadu Accident and Emergency Care Initiative. Related details were given to us. So we visited, let me congratulate Tamil Nadu at first of all, because we had a glimpse of a fabulous state level lab with so much of cleanliness, methodologically presented, put up, taken care, manned, as well as explained in a detailed way in such a short while that we just could think of one line. That was too big a standard for us to set for ourselves as on today. Definitely we can achieve it later on. So the state, no, it was really good, and the kind of equipments we saw, I think we can't even think of in dreams right now. Even in dreams, we can't think of those equipments. And the good thing was, none of them were sponsored, means the biggest equipments like CLI machine, it was not sponsored by Government of India, it was taken by the state itself. So for us states, we think that everything we have to look towards Government of India. So the Tamil Nadu is a pioneer as well as a model to be followed in that way, though it goes against us, all the states sitting over here. So we had a laboratory quality management system in that, which was very nicely placed up and meticulously taken care. The focus was more on the internal quality control and the external quality assessment scheme implementations. And the good thing which we found was there was a genome sequencing for the diseases like dengue and COVID, and they are starting, including few of the things like Zika virus and other virus, Zika and other things they had come in between recently. They are trying for the screening of those also, sequencing of those also. Leptospirosis, which normally we skip out, and they have a very detailed program management of leptospirosis sequencing also. This regional leptospirosis diagnostic lab for One Health, it's a new takeaway because this kind of diseases we normally skip. There is a different microbiological and biological test under one roof. It's kind of a holistic, a complex is made, and there is a strong laboratory referral systems were there. Like they are the pioneer in the sense that they can be replicated, and they had been integrated with the district level things, and the information system is so strong and fast that the disease prevalence and the surveillance, it can be taken up very fast, and that's how the state has been able to maybe cope up with the kind of viruses which come in Kerala, and somehow it is able to shield themselves, those viruses not to be coming to Tamil Nadu. So this, most of the equipments were well placed, we already have, but they are 2 to 3 tier above the equipments what we are having right now today, including our IPHL as well as our any of the diagnostic complexes. They don't fulfill the criteria what equipments Tamil Nadu State Lab today they are having. So I'm not finding a word to explain how to say what I have to take away with this. It's really good. That's the only thing I'll say. Second thing, we had visited the maternal mortality rate reduction ke liye, they had established a war room, which is a very unique kind of a thing. We had war rooms during the COVID. We had war rooms for other things, but especially for the maternal mortality. This is the focus and level of understanding of the importance of a mother and the newborn child. It was fabulously set up with lots of meticulous behavior has been thought before creating this whole SOP. So they have a strategies to reduce the maternal mortality. I'll say the tracking of the high-risk mother and the follow-up, especially the HRP. HRP has been bifurcated into 2, 3, 4 stages. Their hospitals has been bifurcated into level 1, 2, 3. The best thing which I found is that they have added the private hospitals into it, where we miss most of our maternal mortalities as well as the neonatal mortalities, or even our HRPs, which we could have prevented to become a mortality. They have focused on that. Call center, there are 2 levels of the call center for the high-risk mortality. There is a state level call center, there is a district level call center. And they track the high-risk pregnancy in different days, like 10 days, then next is 15 days, then 20 days, 20 months, first trimester, second trimester, third trimester. And just before the last trimester to be over, they track it after every fortnightly. So that's how I think they have reduced, there is this drastic reduce of maternal mortality in the last few years. And the major reduction had come, which we found it is somewhere in 2012-13 when they had gone for a CMOC trainings and setting up of the CMOC complete setup. So I think the takeaway could be that the CMOC setup, infra as well as the trainings can be increased and we can reach to 1 level. And second is the setting up of the war room kind of a thing and call centers. Then there is a TAEI center, like it's a Tamil Nadu initiative for the accident victims, which in the morning we had a session from the Government of India regarding the accident victims, cashless free medical care during the emergency. The clustering of the hospitals have been done, they had been impaneled, and then hotspots have been found out, and 108 ambulance, they take these patients who are there, and the government give them services free of cost. The triage is the key point in that. The triaging is the most important point. First is a call, then picking up, bringing it to the center, immediately taking care outside itself, then arranging the emergency people inside, and then taking it up. Within the 48 hours, all the things has to be done and taken care. The golden hour is taken care in that way. So few of the key challenges, these are the 3 different things which we found, these are really unique and then can be replicated into other states. The 108 has been utilized in both ways, in the MMR war room also, as well as in this accident victims case also. So it's a beautiful utilization, but we found there more things can be done with respect to, because we vary in different parameters, cultures, terrains. So there are other different hindrances, and the budget is one of the biggest one. The key challenges faced in the implementation of PM-BHIM, as per what are the other state members they had told, is one is HR unavailability, especially the public health managers, epidemiologists, and the TORs has to be revised, and it should not be tied up especially by the Government of India, because different states have different qualifications and they get difficulty in getting the HR. Delay in handing over of the CCBs by the executive agency, so they should be given an extra time. Sustained support of the HR after the PM-ABHIM scheme is over. So that is the next challenge which we will be getting it into. And regional and terrain challenges, which I already spoke about it. Duplication of the lab equipments of DPHL and IPHL, but still this can be taken care by us only. Training of the staff. HR dealing with the BPHUs, IPHL, as well as the CCB is the most critical and the most important point. Because if the training component is not taken into that qualitative level, we will not reach to the quality which we are expecting actually. The guidelines from the Government of India which comes to the state, it's a suggestions from all, that they should have one line added into the guideline at the end. The states are free to modify the minimum things within the ambit of it. For example, I was told that in epidemiology, the qualification is different what is there in Tamil Nadu, and it is different in the Government of India setup, and it is different in some other state. So states like Uttar Pradesh, it is very sensitive in many aspects. If we deviate little bit from the Government of India guidelines, we get lots of pressures from so many different angles. So it becomes difficult. With a good intention as well as honesty and an intent to a good thing, we get a problem into it. Next is the NQAS. I think NQAS, everybody think NQAS should be taken on lead instead of taking Suman, Lakshya, Kayakalp. They all should be merged into NQAS. That should be the bigger umbrella. And the sample transportation linkages is a bigger challenge for us. Once these labs are established, how the samples will be transported, how they'll be picked up, and the budget we have calculated, it seems to be very huge, which is difficult for the states to cope up with. So we need a support from the Government of India. the state's expectations in the new areas for the PMBHIM 2.0, IQUAS and IQUAS has, internal quality has to be focused upon. Trauma care, it should not be the CCB, it could be the trauma care block, so that there is a flexibility in utilization of those infrastructure work pending may be extended beyond the continued time, flexibility of expenditure within different heads. Like its construction, diagnostics, HR, as well as recurring, there should be a little bit flexibility given to the states. IT-related linkages, especially the LMIS, integration, training, and expansion has to be taken further. Trauma care with the IT support can be mimicked in other states. And all three good innovations as well as hard works which we have seen in Tamil Nadu, I think they are worth replicating in other states. I congratulate once again Tamil Nadu for hosting us, for giving such a fabulous opportunity, and Government of India also for giving an opportunity to us to come over here to have a good coordination, discussions, learnings, as well as lighter way of cultural events, and making us understand how another state of our country works. The major difference which I found since I worked in both the state, it is the intent as well as the culture. Second, comes the money. Money had never been a constraint. Money is not a constraint, but definitely culture change, behavior change, trainings, and a constant hammering. And there is one line, होने के लिए एक ही बार काम होता है, ना करने के 1000 बहाने हैं. And whatever is being monitored is being done. The way PM ABHIM has picked up in last 2-3 years, it is tremendous, ma'am. I'm telling you, though it's the last year, but the actual work had been done in the last 2 or 2.5 years. I congratulate all and thank you all. And on behalf of Group 4 and our ACS Gayatri ma'am, on behalf of them, I thank you again all. Thank you.
Thank you, Team 4. That was a very in-depth presentation. If I may please welcome from Team 3, Dr. Suman Singh, Mission Director, NHM Chandigarh, and Dr. Suryanshu Ojaji, State Nodal Officer, PM ABHIM, Uttar Pradesh. They had visited the Block Public Health Unit at Kelambakam and the State Public Health Laboratory at Thenampet, Chennai. They're going to be taking us through their findings and their reflections. Over to you, ma'am.
Good afternoon, ladies and gentlemen, Secretary ma'am, my esteemed colleagues. We are here representing Group 3. So we had the privilege of visiting So the facilities visited by us were the Block Public Health Unit, Block Public Healthcare Center, Kelabakkam, 108 Emergency Ambulance Service, and the Directorate of Public Health and Preventive Medicine, State Public Health Laboratory. The key field observations, the pointers which have been given to us, I'll take them one by one. This was the composition of the team, and this was the HR available at the facility we visited. Now, the best practices adopted by the state for the timely completion of the infrastructural works and the implementation were leveraging the existing state public health labs and district public health labs infrastructure into IPHL, assured upward and downward linkages with established lab sample transportation, use of integrated essential lab system, and the lab management information system for improved turnaround time, in-house procurement system, the centralized TNMSC, environment surveillance system, where the water sample analysis was one of a kind which we had never seen anywhere else, a curated package of screening tests for NCDs at IPHL, appropriate delivery, digital integration, and utilization for all the software for service delivery. The key challenges which are faced in the implementation of PM ABHIM based on the state's experience were the supply chain of reagents and consumable monitoring at each facility level, HR shortage at spokes, BPHU visited, only 2 LTs were available for limited timings. The block PHC was upgraded to a 30-bedded CHC, having OT facility which was underutilized due to the shortage of HR, analysis of the lab and water sample and sharing the reports with the peripheral labs for developing preventive strategies, and BPHL lab had only one semi-auto biochemistry analyzer and a cell counter. However, only 35 tests were being done in-house, and lab surveillance for incidental findings were not in practice.
Expectations from PM ABHIM 2.0 is are the flexibility in reallocation of funds under PM ABHIM, training and capacity building of HR. This is very important point which well covered by MD ma'am UP, and strengthening of the sample transportation and LMIS system in PM 2.0, PM ABHIM 2.0. That is more important as we visited today in Tamil Nadu. They have well replicated it over here. Creating imaging, ECG, teleradiology component under one umbrella. This is very much required since only BPHU signals only that there may be lab services as of now. But if we'll inculcate ECG services, teleradiology as well, this will help a lot. Skill development labs, yes, very much needed. Capacity building of the HR working in BPHUs, IPHLs, and CCBs are very much required. Strengthening environment sampling. Tamil Nadu is doing very good work in water sampling as well as vector sampling. They have formulated a good concept that track the mosquitoes, don't run behind the disease. So it is a good concept what we get from here, and environmental sampling is very important in this aspect. Mapping and linkages for improving diagnostic capacity for CBRN activities. Yes, this is very important point since in current scenarios, biological wars and radiological wars are expected in near futures. So state must have equipped with CBRN activity in any form, though it may be some lab there in state. But ma'am was saying lab is already there. We need strengthening of such kind of lab. Next, utilization of whole genome sequencing for diagnosis of hemoglobinopathy. Though it is well covered in IPHL, we are providing HPLC machines, but it would be better if we utilize WGS for diagnosis of hemoglobinopathy. Thank you. That's all. Thank you.
So the takeaways from the workshop are that the Tamil Nadu IPHL and BPHL models are good replicable practices for adoption by the other states. Training for all the HR on quality management systems at the IPHL and environmental surveillance, that is the water analysis, becomes a very important component. I will just like to add, ma'am, that for any healthcare facility or the system to work, the infrastructure, the equipment and the consumables and the HR form a very huge component. And then unless all the three are in place, I don't think we could go anywhere. So we would like, at the end of my presentation, I would like to thank Tamil Nadu for being such excellent hosts and all analysis done, but still I think they have done a very good job and it was a treat to go and see their facilities. Thank you so much.
Thank you, Team 3. And with that, we have our final team joining us on stage. May I please welcome Team 1. I'd like to invite Dr. Abhyuday Shakti Tiwari ji, Nodal Officer from Chhattisgarh, and Dr. Valerie J. Lalu, from SSO from Meghalaya, who are going to be taking us through their findings. Their visit was to the critical care block at Government Chengalpattu Medical College Hospital, following which they also had the chance to visit the Block Public Health Unit at Block PHC, Kelambakam. If I may please welcome our presenters to join us on stage. Over to our presenters from Team 1.
Very good afternoon, everyone. So as Team 1, that's the team that we have, which is headed by Shri Anup Kinchi of Nagaland, and we have various officials from NHM, SNOs from various states, officers from the ministry, consultant and advisors, and other officials. So let us talk about the place we first visited. That was Government Medical College in Chengalpattu. I hope I've said it correctly. So it is a 50-bed. We first went to the medical college and visited the medical college where we had a small presentation from the college. And following that, we visited the CCB of that, which is adjacent to the college. And it was a 50-bedded critical care block hospital. And another facility we visited is the BPHU in Kalambakam Block PHC. So the 50-bedded CCB which we have visited, that is just next to the Government Medical College, and it was a new infrastructure. It started functioning around just 2 days back. So everything is brand new about it. And the facility itself is a 4-story building, and it had all the facilities that are prescribed as per the norms for a CCB. When we entered the facility, we entered into a triage area first. And that triage area, following that, there were other rooms, casualty rooms, which were 5-bedded, and they were color-coded. So as per the triaging, color-coded into red, yellow, and green rooms, depending on the, the type of trauma. And of course, for the black zone, they have a separate facility for broad death and other patients, which they keep in a separate facility. Now they also have decontamination room, which has, it has a wash area for any chemical contamination or zoonotic disease or any other, diseases like, not exactly disease, but events like dog bites and other things where they have their wound washing area. Then we went to another floor which had a blood center. Of course, the blood bank has not been started there, but all the facilities are available. Then it has a neurology ward with ICU. Then it has another HDU and a step-down ICU. They have surgical ICU, dialysis unit, trauma specialty ICU, nephrology ward with 12 beds. It has 2, in the other floor, it has 2 OT complexes, one for general surgery and others for trauma specialties like orthopedics cases and others. And the best part is that every floor is connected to the existing structure at the medical college or the Thai centers, as we call it. And they have, each floor is connected to the Thai center. So every, there is a synchronization between the services. Then we have HR from the existing staff, and service delivery is, it has a catchment area of 636 villages, whereas we have not seen any connection with the IPHL, IHIP portal. Then we have, these equipments are there at the facility, that is the emergency room. The challenges that they have faced is the fund allotment, which they say it is not enough. We have not seen any, they say there's no AC in the ICU, but of course there was some, but there was, it's not enough. No MCH beds. Of course, the MCH services, here it is not catered to, so maybe MCH services and labor rooms have to be incorporated in this CCB. Yeah, so I hand over to my colleague for...
Thank you, ma'am. So moving forward to the BPHU, so the building is perfectly designed as per the BPHU norms, the more than 2,500 square feet building, the single-story building, containing all the essential space requirement as per the BPHU requirement. Wonderfully, the human resources also in the place what is expected at the BPHU level. Service delivery is concerned that there is a 35 in-house tests, 62 tests are being done outside. Average footfall is 40 to 45. And the transportation of sample from the peripheral spokes on alternate days So equipment is also available. Linkages, so there are two things that is a more important, that one is the number of tests being done at the presently BPHU. The scope of expanding the number of tests is present. Maybe we can add some few equipments and we can done some tests at the BPHU level. So the number of tests which is going for the outside can be reduced. Linkages with the ASPLN form, number of facilities given, but the linkage is manual currently in the BPHU, where we have scope with integrating with IHIP portal and HMIS. Currently they are using IES software, which is a state-owned software, but not integrated with HMIS and IHIP. So the manual surveillance is being done at the BPHU level. So the critical care block best practices, what ma'am has discussed, the trauma registry is available with the color-coded alert system. The main, the advantage to the Tamil Nadu that they have already the TAI program, so they get help from there to expand their CCHB and make it functional immediately. And 48 scheme for ensuring caseless treatment within a 48 hours of for the road traffic accident victims. CCSB plan to use the existing state insurance scheme for HR. Clear SOP protocol are in place and the clear plan for using CCHB during emergency operations. So what is the key challenges in the implementation? So as discussed with the functionary, the budget provided for the make this CCHB functional is, especially in the time of pandemic when we expect it is being used as a standalone facility, the high-end equipment like CT scan, X-ray and the medical furniture firefighting system, the fund is not sufficient or not at par with the service delivery what we are expecting at the time of currently we can manage the both facility with the same resource, but that time. And second is the providing fund in the flexi head rather than strict with the headwise for the different area, like we are facing, like some states are facing that they cannot use the different head fund in the for use of their infrastructure, where they can exhaust one head, but the remaining head is the same, the amount is present in the same head. State expectation, as infrastructure-driven project need to extension for the project period, integration of various software with HMIs and IHIP portal, especially for the LIMS, which we have discussed in the previous session also, and the dedicated support center for the integration of LIMS and software with at the central level as well as at the state level. And HR support until the program gets strong is highly required for the states. So, so takeaway from the workshop is the linkages of CCHB with the respective departments. So CCHB should not work in the silo. So different departments should integrate. So there the functional integration must be ensured at the to make it functional. And especially the integration of all these three units, CCHB, IPHL and BPHU, is a very crucial for the effective service delivery in the future and for the lab-based surveillance. Source of funding for various state initiative in ensuring access to healthcare and sustainable model and plan to be explored for continuous functionality of CCHB, because the CCHB is a highly HR required institution. So how to sustain, we should explore some model like either integrate with the state insurance scheme or some other model to make it CCB functional. Thank you so much.
That was team one. Thank you, sir. Thank you, ma'am. A very special thank you to all of the teams for sharing their valuable findings and insights on way forward as well. With that, the topic before us is an interesting one: financing health sector projects in public-private partnership mode. To take us through this critical session, it's my pleasure to invite Shri Vijay Nehraji, Joint Secretary, Procurement, Ministry of Health and Family Welfare. Good evening, sir, and welcome.
Respected Secretary Ma'am, senior officers, and dear colleagues, I think we have been witnessing some very good presentations in the last 1 hour. And the good thing is now that we are done with all the presentations, I can see that the audience are de-stressed now. They were quite busy preparing their presentations in a very short period of time. And now that coffee has been served, I expect that everybody will be attentive to this very important topic. Because when I realized that so many important people are going to be together, I requested my friend Saurabh if I could also get an opportunity to share something with all of you important people on this very important subject of public-private partnerships. This is something new. Recently, Secretary Ma'am has taken a decision to create a dedicated PPP cell in the Health Ministry. And over the last 2 days, all of you would have seen the importance of creating health infrastructure. However, I think all of you working at the state level would agree that we do not have enough financial resources to take care of all of the requirements for health infrastructure and health services that we need at the state level. A large part of our funds under NHM specifically go towards managing HR, incentives, etc. And we are not left with enough fund for all the infrastructure requirements. So it is in that context that over the next few minutes I'll be sharing with you what are the schemes from Government of India which will enable you to address the requirements of infrastructure in your states. And believe me, for most of you, it will come as a pleasant surprise. For several of you, it will be a new information, and some of you might feel that this is a good information which you can utilize to try and achieve what you are working towards. So the context here is that in the budget announcement in this year, there was a specific reference that all of the infrastructure ministries will create a pipeline of projects for the next 3 years that can be implemented in the PPP mode. And the states also are being encouraged through all of the line ministries in Government of India to do this. Traditionally, PPP projects were used more in physical infrastructure, in airports, roads, ports, etc. But now the focus of Government of India is more on social infrastructure projects. I think all of you are aware about this, how PPPs can help bring private investment and private efficiencies in delivery of healthcare services. I've already mentioned about the creation of a new PPP cell. So whenever you need any hand-holding, any facilitation, there is a single point of contact now in the Health Ministry to help you, to work with you, to be able to do these projects. This is the most important part. Now, Government of India has 2 specific schemes. The first scheme is to provide for viability gap funding in PPP projects. And the second, some of the state governments reached out that they do not have the capacity to undertake the transaction advisory services to design and implement the PPP projects. So for that, there is another scheme under which support from the Government of India is being given to state governments to onboard transaction advisors, consultants, etc. And the support under the scheme is significant. The second scheme I'm saying, that up to 5 crore rupees per project is being given by Government of India to state governments to design projects. Just look at this slide. For normal sector projects, physical infrastructure, the third row, the total VGF is 20% by Government of India and 20% by the state government, a maximum of 40%. But for social sector projects, this goes up to 60%. And the second row, if you see, in health sector, for pilot and demonstration projects, we can give a viability gap funding up to 80%. This would essentially mean that in any remote area of our country where traditionally a PPP project would not have been viable, because of up to 80% of VGF, the projects will become extremely viable and we'll be able to attract the private sector, the private investment, and be able to provide the services. I've already mentioned this, the second scheme, up to 5 crores per project. And as of now, there is no cap. So as you will see, that unlike all of our other schemes in which all the states are being treated in the same manner, this particular scheme, proactive states will end up getting more funding from Government of India. This is an example. So while some of us might be thinking that we are yet to initiate discussions, there have been some state governments which have taken the initiative. Uttar Pradesh is leading. They have got approval for 6 medical colleges under the PPP mode. The total project cost of the 6 medical colleges is more than 1,500 crores. Odisha, they have got 4 projects approved already, more than 350 crores for the development of affordable healthcare facilities at district and sub-district level. Arunachal Pradesh, such a pleasant surprise. The Arunachal Pradesh state government has taken initiative, and recently, last month, we have given in principle approval for the construction of a medical college. Project cost more than 350 crores. Jharkhand has prepared and submitted 5 proposals costing more than 1,550 crores, which are under appraisal and are expected to be cleared soon. So this gives us as a glimpse that those state governments which are taking the initiative are being able to secure more financial resources from the Government of India. These are some of the suggested possible areas just to encourage you to start thinking on this line. We can build medical colleges, trauma centers, PHCs, CHCs, district hospitals. We can take greenfield projects where we start from scratch, new building constructions. We can take brownfield projects, geriatric centers, cancer care centers, radiotherapy centers, radiology, diagnostic labs. So the scheme does not specify anything. It is very open-ended. It is upon the initiative of the state government, your imagination, the way you conceptualize services. For example, any state government can plan of rolling out dental care units in all of its CHCs or PHCs under this scheme. You can plan rolling out mobile diagnostic vans, mobile medical units, home-based geriatric services. So our imagination is only our limit. Any state government which takes the initiative, it's apparent that they will be able to significantly enhance the quality of healthcare services in their particular state. Now, the best part, we will be hand-holding you. So the state government just has to take a decision that yes, they want to improve the health infrastructure and healthcare services in their state. And you just have to reach out to us. From that point, we'll be hand-holding you right from the point of helping you conceptualize the project, onboard the transaction advisors, prepare the preliminary proposals, the detailed proposals, get the in-principle approval from Government of India, and get all of the funds released, reimbursed, and manage the entire transaction. All you have to do is just log on to the website. Somehow it's not featuring here. Yeah, that's here. I just want you to go back with these 2 bits of information. The first one is the website pppinIndia.gov.in. So I assume that there are a lot of people in your state level offices who can be tasked with this job that they can go to this website, study the guidelines of both of these schemes, and then the next is a small email ID which you have to note down and remember. If we get an email from any state that they are interested, from that point, we will be hand-holding you, we'll be working with you, and we'll be ensuring that you can fully benefit from this scheme, which for some reason we could not earlier convey to you that this is a scheme under which there is no budgetary ceiling, there is no limitation. It is all about your initiative and what you can achieve with that. Once again, I would like to thank all of you for a patient hearing, and my special thanks to my friend Saurav for giving me this opportunity to share all these details with you. Thank you so much.
Thank you, sir. If we may please request you to remain on stage for a quick minute, sir. If we may request you to remain on stage, I'd like to take the opportunity to welcome Dr. Arun Thamuraj Avargal, Mission Director, NHM Tamil Nadu, to extend a mark of our honor and gratitude to Shri Vijay Neraji. We have, sir, presenting Shri Vijay Neraji with a Tanjore painting. All of us in the audience, of course, know the richness, the cultural heritage, and the divinity that comes along with Goddess Madurai Meenakshi in all her glory. And of course, we are presenting a slice of Tamil Nadu to you, sir. So we truly hope this souvenir stays with you for a long, long time. Thank you very much for your presence here. And with that, ladies and gentlemen, we come to the final and perhaps the most significant segment of the workshop, the way forward. If I may please have the honor of inviting Srimati Punya Salila Srivastava ji, Union Secretary, Ministry of Health and Family Welfare, Government of India, to join us on stage and share her valuable insights. Of course, over the course of the past 2 days, we have had the opportunity to engage in deep deliberations, a few field immersions, and I'm sure a lot of meaningful exchanges. This segment is going to share ma'am's valuable inputs, a consolidation of everything that we have seen over the last 2 days. Ladies and gentlemen, if I may please request you in joining me in welcoming Srimati Punya Salila Srivastava ji.
It's okay. So, good evening, everybody. I think the way forward has already been laid out in the 5 presentations which we had today afternoon. And I thank Tamil Nadu government, the MD NHM, and the Secretary for giving all of us the opportunity to be here today. I think Chennai was a beautiful location because it allowed us to see the wonderful efforts, the innovations done by the state government in making quality health care available to their residents. And we also saw some central government initiatives here. So PM ABHIM is, as you know, an effort to boost emergency preparedness at national level through the central system as well as through the healthcare systems which are being got readied by the state governments. So Chennai was really a unique blend of the two, and your visits, your preparations, your observations have, I think, brought out a very holistic picture for all of us, that if we want to do pandemic preparedness, if we want to have emergency preparedness, what are the things that we ought to do? I also thank you all for your patience, because apart from discussing Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, today with Vijay Nehra's presentation and yesterday with the presentations that we had after the lunch break, we tried to bring to you all the initiatives which are in pipeline in the central government, because often we realize we issue a letter, we write a DO letter, but the thrust of the initiative does not get conveyed. And this, I'm told, was brought out in the case of PM ABHIM, that everybody said that they didn't have the holistic picture of what central government was doing up till now. Of course, I wrote letters that please sanction land for NCDC regional branch, please help us set up a quarantine center, or set up the HEOCs. But I'm sure that the presentations that happened yesterday would have brought home to you the point as to why we were pushing for those initiatives.
I think today's mobile world, these national level initiatives, whether it is IHIP or the IHIP IDSP or the health sector disaster preparedness and response mechanism that Dr. Khasnobis would have presented, or the emergency and trauma care cashless treatment for road accident victims, which is in pipeline, it becomes very important for all of us to be aware about its details. And I think with your inputs, we'll be able to make each of these initiatives much better. Today, there have been so many important points as to how there should be more flexibility in all of our schemes, whether it relates to HR qualifications or whether it relates to funding under different heads. I will request the PM ABHIM team that we go back and see if there is some way by which we can take some kind of approval from the mission steering group and make available this flexibility to you, albeit at a slightly late stage. I think the best part about the visits that you had, you saw how Tamil Nadu government has been stressing on quality control measures in its facilities. So one is the funding that the state government put to it, but the second is how to ensure that the services are of a certain quality. So this, I think, is a big takeaway for all of us. I think Dr. Pinky mentioned the MMR war room, and many of you have mentioned the Tamil Nadu initiative for accident victims. And these are things that, these and other things, whatever initiatives you have found scalable here or in your state. Yesterday, I mentioned it to the secretary and to the mission directors. Please do share these initiatives with us, because we are at the critical juncture of planning for the next 5 years. So for PM ABHIM, I think you all have given a number of inputs, but whether it is NHM, whether it is other healthcare initiatives, don't be restrained. Please share with us that this is something you feel that the central government can put in its next mission document, or even create a new mission for something, for whatever health sector initiative you think important. So this is something that I look forward with each and every, from each and every person in this conference room, that please do think as to what more can be done, what can be done differently, and what for being institutionalized requires more effort in the next 5 years. While yesterday evening I mentioned an important initiative that is coming forward in this particular month, in the coming month, is the Swasth Nari Sashakt Parivar campaign. We will be sharing in detail with you. It is what you already do at field level, but to do it more intensively and with a focus on women. And the purpose would be to ensure that the screening of women for non-communicable diseases, hypertension, diabetes, oral cancer, breast cancer, cervical cancer, anemia, anemia happens, tuberculosis screening happens, sickle cell disease screening, card distribution and counseling where it's relevant, ANC checkups, distribution of MCP cards, immunization services, awareness sessions on menstrual hygiene and nutrition for adolescent girls, counseling sessions for the anemic patients as well, and of course, to keep us all healthy, the campaign on 10% reduction of cooking oil. And maybe you all can say how to best involve self-help groups and women representatives in the PRIs and other public representatives. So why I'm mentioning this specifically is that often we think that we are doing well. We have screened, say, 4-5 crore people for sickle cell. But then when you look at the national level data, you find that the cards have not been distributed or the counseling services have not been carried out. So this particular Abhiyan, which we'll do from 17th September or 18th September till Gandhi Jayanti, there let us at least ensure that these gaps which are there in completing the chain from A to Z are covered. One important suggestion which came from a number of presenters here was the integration with IHIP platform. This I'll request all state governments that please do go back and look at it. I'm sure Dr. Himanshu Chauhan would have made a presentation on that, but that becomes a very important source of data when we are planning initiatives at the national level, whether it is to send a joint outbreak team. I saw mention of One Health. So the One Health teams which NCDC sends out, for that, this kind of a data is very important because the picture emerges. I would request some of you, whenever you come to Delhi, if you haven't visited already, do visit the NCDC, look at their IDSP, IHIP setup, give more suggestions as to how to improve it, and share the data on the IHIP platforms. I want to emphasize that One Health is a very important part of the PM ABHIM philosophy. And therefore, it's very important for us to look at each of these initiatives that we have taken to see how it is feeding into One Health. One Health is simply, you all are aware, and you would have probably discussed it in the last 2 days, is to ensure that whenever how to prevent outbreaks by detecting the progress of disease early, and how to respond to it in a very cohesive manner. I'm sure the team from J&K is probably here, but if you recall that when you have mysterious illnesses, if you go about it scientifically, you realize that it is not all that mysterious. If you are able to take a very holistic view. You test, yesterday also evening somebody mentioned, you test the food that is lying in the house, you test the crops, you test the water sources, you try to gauge from the symptoms what can be done. And these become very important when you want to save lives in a timely manner. So with these words, I would just like to say that thank you to all for participating in today's workshop. Thank you, Tamil Nadu, for organizing this excellent session. And thank you all for your very incisive comments. The comments were actually very incisive, and I think it makes a difference when the secretaries and the MDs are collating their comments, because it comes out with both a holistic picture, and with the rest of the team being there, it brings out the nitty-gritty as well as the holistic picture both. And I'm sure you have a lot of takeaways, and together we will make a difference, and we will ensure that our health infrastructure mission gives results. And last bit, जितना हो सके उतना इस साल ही कर लीजिएगा, because the more you do, the more I can go and demand from the government. So the more things you can operationalize in the next 6 months we have. September, October, we have more than that. We have 7 months. So let us try to do our best during the next 7 months, so that when I go asking for budget for each of our initiatives, I have good evidence to back me up that you please give us the budget and my team here can do it. All the best.
Thank you, ma'am. If we may please request you to remain on stage as I welcome Dr. Arun Thamburaj Avarkal, Mission Director. Ma'am, if we may please request you to join us on stage, a symbol of our big gratitude and honor. We're truly excited that you share the optimism in the room. And with that, we have Dr. Arun Thamburaj Avarkal presenting a Tanjo painting of Lord Perumal, of course, a coming together of intricate craftsmanship and spiritual depth, both of which Tamil Nadu is known and loved for. Thank you so much, ma'am, for your presence here. Ladies and gentlemen, with that, we draw to a close our formal proceedings at the National Workshop on Strengthening Public Health Infrastructure under PM ABHIM. Of course, the last 2 days have been full of deliberations and field experiences. But before we officially draw to a close, if I may please request all our guests to rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विन्द हिमाचल यमुना गंगा उच्चल जलति तरंगा तव शुभ नामे जाहे तव शुभ आशीष माहे गाहे तव जय गादा जनहन मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
As we extend our heartfelt thanks to all of our guests who've joined us here, if we may please request all our NHM members, liaison officers, state officials to join us for a photo op outside. We'd like to have a commemorative picture of the National Workshop. And in order to have a complete picture, if I may please welcome the NHM guests, liaison officers, state officials, to join us outside. Tamil Nadu NHM guests. May I please request Tamil Nadu NHM guests to join us.